Hello, mic testing 1, 2, 3. All right. Good morning, all. First of all, I want to tender our apology to the participants, both who are here and those who are online, as the program already has scheduled to begin by 10 a.m., but due to some circumstances we are not able. Please, we tender our apology. We do not mean for that, please. As usual, the first thing in the agenda is the opening prayer and introduction of guests, which I will deliver by myself. Sallu ala Nabi. فاتحة لم نشرح. سبحان ربك رب العزة عما يصفون وسلام. Hello. سبحان ربك رب العزة عما يصفون والسلام على المرسلين الحمد لله رب العالمين. The Director General, Kano State Primary Healthcare Management Board, Dr. Muhammad Nasir Mahmoud, ably represented by Director Administration and Human Resources, Kano State Primary Healthcare Management Board, Malan Jazuli Jafar, the Director of Disease Control, Kano State Primary Healthcare Management Board, Dr. Sharif Yahya Musa, the representative of the directors, Kano State Primary Healthcare Management Board, who are here present, the donor directors, Kano State Primary Healthcare Management Board, PM Serik, Kano State Primary Healthcare Management Board, Awal Idris, other senior staff from Kano State Primary Healthcare Management Board who are here present, the Executive Director, TA Connect, represented by Dr. Lai Jayola, and the entire team of TA Connect, Kano and Abuja, members of the press, other special invitees, distinguished ladies and gentlemen, good morning. Good morning all and welcome to an end of project dissemination meeting on accelerating vaccination uptake in children under 2 years in some selected zero-dose LGS in Kano State, organized by Kano State Primary Healthcare Management Board in collaboration with TA Connect, supported by Pfizer Foundation. Let me, at this time, quickly go to the second item in the agenda, which is welcome address by Director Disease Control, Kano State Primary Healthcare Management Board, as I said, Dr. Sharif Yahya Musasa. All right. Please let us appreciate the effort of Director Disease Control, Kano State Primary Health Care Management Board.
Thank you very much. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم سيدنا رسول الله صلى الله عليه وسلم. Should I apologize before I say my welcome? I think we plan to start the meeting by 9, but they invite the facilitator never say 9 for 9. Maybe that's why some people are still coming. So let me tender my apology on behalf of the team for commencing this meeting a bit late. The Director General, Kano State Primary Healthcare Management Board, ably represented by the Director, Admin and Human Resource from Kano State Primary Healthcare Management Board, other directors from Kano State Primary Healthcare Management Board, the Program Manager, PM Serik, Kano State Primary Healthcare Management Board, the Zonal Directors who are here with us, the Technical Director, the TA Connect, the Technical Manager, the Program Manager, Program Coordinator, Kano Connect. I'm sure they are here with us, and other team members from the Kano Connect, TA Connect, other team members, other partners who are here with us. Let me appreciate everybody for coming to discuss with us and seeing what is the finding from the field for us to discuss and find way forward for the activity that the team have done in the field. And I hope at the end of the day, the document will be utilized appropriately by the appropriate organization. When I say appropriate organization, most likely people will say the SERIC team, the Kano State Primary Healthcare Management Board, the Kano State Ministry of Health, and Kano State Government. So let me, on behalf of the Director General, Kano State Primary Healthcare Management Board, and the Director, Admin and Human Resource, welcome everybody to this meeting. And I wish the meeting will be successful at the end of the day. Thank you very much.
Please, another round of hand to Director Disease Control Council. So now, I'm going to call for a welcome.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إن الحمد لله نعمده ونستعينه ونستغفره ونعوذ بالله من شرور أنفسنا ومن سيئات أعمالنا. The Director Disease Control and Epidemiology, Kano State Primary Health Care Management Board, the Program Manager of SERIC, other invited guests and our partners, Ladies and gentlemen, Assalamu alaikum wa rahmatullah. I stand on behalf of the Director General Kano State Primary Healthcare Management Board to deliver the opening remarks of this end of project information dissemination on some selected zero-dose LGS in Kano State. We really appreciate the effort of the partners in partaking in this project, and we are looking forward to a more collaborative partnership between our partners and the Primary State, Kano State Primary Healthcare Management Board for an improved and sustained healthcare delivery services at the PSC facilities. I welcome you all and thank you very much.
Thank you very much, sir, for the brief. The next is the objectives of the meeting by VM Serik Alaji Awalu Idris, sir.
The Director General, ably represented by Director Admin and Human Resource, Director Disease Control in person of Dr. Sharif Yahya Musa, all important dignitaries here present, including our zonal structures, the supporting partners who are also here to witness this important end project dissemination meeting. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Behind every gathering, there should be an objective of that activity. So quickly, let me take us through the objective of this dissemination meeting, which include objective 1, share the achievement, outcome, and the impact of the project with broader stakeholders. We are all aware that this TA Connect organization came to Kano to support the uptake of Rota and other RI-related antigens. And this is the phase 2 activity. If we can recall back, they were in Kano to support phase 1 across some zero-dose LGS, but targeting only Rota antigen, which later, the result we have recorded indicates that there is need to also include other RI antigens. Then number 2 objective is to highlight lesson learned and the best practices for future scale-up and integration. By way of explanation, I think that a lot of lessons were learned during the inception of this activity, because we can see commitments, accountability, and so many other interventions during the project tenure, which I believe if we can domesticate this lesson learned across the non-implementing LGS, a lot of success will so far be recorded. Then number 3 is to promote dialogue on sustainability strategies for maintaining and expanding the gain of the project. I think this slide is also speaking same as that of 2, because it's really a good strategy which include integration, and any activity that integration comes in, definitely a lot of success will so far be recorded. Then lastly is to foster stakeholders' ownership and the support for continued investment in zero-dose and the integrated PSC interventions. I believe for those that are aware, out of the 100 prioritized LGS considered to be zero-dose, cannot contribute the lion's share. Cannot contribute 15 LGS which a lot of interventions are happening so that we can bring to an end to the menace. Next slide. Thank you for listening.
Please, another round of hand to Mr. Awalu. So now the next in the agenda is to receive goodwill message by partners. I will begin to call the representative of WHO. Babagana, yes.
أعوذ بالله السميع العليم من الشيطان الرجيم بسم الله الرحمن الرحيم وصلى الله على نبي الكريم. Let me stand on the existing protocol in order to minimize time. WHO as a global partner is mandated to support national, state, LGA, communities in the areas of surveillance, immunization, vaccine and cold chain management, trainings, research and fundings. And let me, on behalf of my state coordinator, say it here categorically that WHO as an organization has a very good relationship with Kano State government, particularly the State Ministry of Health and the Primary Healthcare Management Board. And our main focus is to reduce the burden of zero dose to the BRS minimum and ensure disease-free society. Having said that, I will specifically mention the support and cooperation we have enjoyed, especially from the Director General, Dr. Nasir Mahmoud, and then the Director of Disease Control, Dr. Sherif Yahya Musa, and other colleagues that have supported the cause of WHO activities. I would like to assure the state that WHO is 100% in support of any activity targeted in reducing zero dose and also making Kano to be free from diseases. We are looking forward to open a new chapter with other partners that are focusing on zero dose to also scale the scope of zero dose activities from the 15 prioritized zero dose, in fact, to all the 44 LGS. Looking at our data, Kano has 25 out of the 44 LGS with high burden of zero dose. But due to finances, we have prioritized 15, or the national had prioritized 15. We are looking forward with other partners to also include the remaining 25 so as to have a holistic approach in reducing zero dose in Kano. Thank you very much.
Thank you very much. Also, in goodwill message, I will now call the representative of Pathfinder, please.
Thank you. My name is Gombe Ibrahim. I'm the state team lead of tax shifting, tax sharing project of Pathfinder International. Warm greetings from the senior country director of Pathfinder International, Dr. Amina Aminu Dorai. We want to welcome and of course congratulate the state for this milestone. Despite its in selected LGS, we believe the findings will be able to add value to other partners that are supporting the state so that we can be able to achieve the desired goals of the state. The government, which have shown commitment to its own people, during their campaigns, they promised good health, good education, and other interventions. As partners, we are contributing our own quota to see to the success of what has been promised to the citizens. One of it is good health outcomes. And I think this is an occasion where if we're able to understand the takeaway from this exercise, it will aid in supporting the state to achieve more. After all, we are looking for universal health coverage. We are looking to achieve the SDGs. Kano is contributing to the nation's success of healthcare outcomes. And we don't have to be left behind. We want to be seen as champions. We want to be seen as contributing to the state to achieve the nation's promise to the SDGs and, of course, universal health coverage. So I want to thank the organizers for this, and we're looking forward to the outcome so that we can all partner and collaborate to assist the state in making sure they achieve their targets. Thank you so very much.
Thank you, sir. So the next is the representative of Get Foundation. Doctor.
Across the state. As we are all aware, I know someone must have mentioned this, Kano contributes to the highest burden of RI0 dose in the country and globally also. And we don't want to be, notorious for something negative. So we do not want to continue to be popular for carrying the biggest burden of zero dose in Kano. We want to be popular in the world. We want to continue to be popular for making sure that we are the state that made the biggest gain towards reduction of routine immunization zero dose, so that at the end of the day, we will have healthy children and ultimately a very healthy future in the country as a whole. Thank you very much, and God bless everyone.
Thank you very much, sir. Before then, we want to recognize the presence of Special Advisor to His Excellency the Executive Governor of Kano State on Special Intervention Project, Honorable Balarabe Gaya. Sir, you are welcome. So the next, also in goodwill message, we have the representative of ACASOS. ACASOS, please. He is here, yes.
Good morning, everyone. And standing on existing protocol, I'm happy to be here delivering these goodwill messages. We want to especially thank the Director General of Disease Control and also the State Primary Health Care Board under the leadership of the DG. Thanks to the Director Disease Control and Epidemiology, who has also given us so much support to ensure that we are able to deliver on the strategic objective and the impacts that we want to see with zero dose in Kano State. I've not in details read the reports from TA Connect, but I've seen some of the work that they have done, and I really want to appreciate the efforts that they have also contributed to ensuring that Kano State no longer has a story of zero dose children, and making sure that it becomes a thing of the past. TA Connect, you have done a very good job. We also want to use this opportunity to thank the Gates Foundation for the support that they are giving, not just to our organization, but also to every other organization working here, and also to the numerous funders working in Kano State. Thank you for the support that you are giving to us. We hope that in the nearest future, the objective of ensuring that zero dose is no longer a challenge in Kano will be achieved. And finally, I would want to say that as we have been working together synergistically, together as partners and with the state, I want us to continue to do this, because with this alone is how we can achieve ridding Kano of zero dose children, and ensuring that every child in Kano not only has access to vaccinate, not only is vaccinated, but continue to have access to vaccination. Thank you very much, Kano State government, for allowing all of the partners a playing ground to show what we can do, and allowing us to contribute to the universal health coverage that is the objective and also one of the promises of the government to the state. As ACASOS, we are promising and committing to ensuring that we continue to work with the state, and hopefully in the nearest future, we would all jointly sit here again to appreciate the good work that we have done and the milestone that we have achieved. Thank you very much.
Please, another round of hand to development partners, please. So the next in the agenda is the brief remarks from TA Connect by Technical Director TA Connect, please.
The Director General of the Kano State Primary Health Care Board, ably represented by the Director of Admin and Human Resource, Director of Disease and Control, our own very own, a friend and colleague, the Special Advisor to His Excellency of Special Interventions, Honorable Balarabe Gaya, all Zonal Directors of the Primary Health Care Board, colleagues and friends from partners and organizations. On behalf of the Executive Director of TA Connect, it gives me immense pleasure to join the Kano State Primary Health Care Board to welcome all of us to this occasion. For us at TA Connect, today is a renewal of our commitment to supporting the Kano State government to address this burden of zero dose. Our partnership and collaboration with Kano State has started since 2021, when we've been working with the Kano State Primary Health Care Board to improve maternal and newborn health outcomes with funding from the Gates Foundation through the Group Antenatal Care Project. That has snowballed into our work on newborn and child health interventions, starting with the work with support from Pfizer Foundation to address immunization and improve the uptake of immunization in Kano State. So our work on immunization has started since 2023, when we started the first phase. And that phase focused mainly on rotavirus. And working very closely with communities, with zonal directors, with state structures, we did attain some significant milestones with rotavirus uptake. The successes of that grant necessitated the donors' interest in expanding the work, which led us to the results we'll be disseminating today. And so today we'll be focusing on an integrated approach to address the burden of zero dose. Not only did we focus, like the PM Seric mentioned, not only did we focus on antigens in an integrated approach, looking at all of the antigens within our immunization program, but we also innovatively focused on introducing wraparound reproductive, maternal, and newborn child health services into this program. That itself is quite innovative because we are using the same funding not only to reach children, but also to reach their caregivers through very integrated, innovative approaches. We believe that validates the essence of integration. It speaks to more value for money, and it speaks to more efficiency. And so this journey, which will be disseminating the results, we are hoping that we use these results to introspect and to have very deep conversations on how do we take these interventions to scale and sustainability. And I think those are the key things we need to focus on. These approaches, when we listen to the approaches and interventions, they've been evidence-based. They are interventions we know that work. And with the active support of the Kano State Primary Health Care Board, and of course, the deep, intense work we did across communities. And at this juncture, I also want to recognize the village head of Kumbutu, who is here with us. Again, an eloquent testimony to the deep work we did across communities. The issue around zero dose is trying to reach the unreachable. And until we really take these interventions to where the unreached are, we really will not address the burden of zero dose. And so most of our work are focused on community-level interventions, knowing fully well that until we get into the communities and we reach these children with these interventions, we might not be able to change the narrative of zero dose. And so as we start listening to the interventions, to the approaches, we also have a panel session where we have the state's perspective, we'll have the perspective from the community, from the village head, also giving us granular insight into what has worked well, and to be honest, what did not work so well. I believe all of this encompasses the lessons we need to pick from this gathering. And so from us at TA Connect, we take this opportunity to renew our strong commitment to a very strong collaborative partnership with the Kano State government, the Kano State Ministry of Health, and the Kano State Primary Health Care Board. We look forward to the conversations that will follow with the presentations and the panel sessions. And we hope that we leave this gathering with very clear resolutions and actionable next steps on what sustainability will look like. These results demonstrate that we can reduce burden of zero dose, we can increase coverage and uptake. The key lessons we need to discuss is around scale and around sustainability. And until we address the issues of scale and sustainability, we might struggle with the issues around impact. So again, with immense pleasure, I'm happy that we are here where we can disseminate our story today And we hope that this story starts or serves as a nucleus for the conversations on sustainability and scale that ultimately shows that Kano has turned the bend and has really, really addressed the burden of zero dose. We congratulate the Kano State Primary Health Care Board, led by its leadership, who are ably represented here. Without the support of the Kano State Primary Health Care Board, the communities, partners, we won't be here to share the stories that we have today. So we say an immense thank you to all stakeholders who are here, and we look forward to very deep and sustained collaboration and partnership with the Kano State government, the Ministry of Health, and the board, and of course with all partners that are here. So I thank you very much for your attention, and we look forward to the conversations following on the lessons that we have, the successes we have, the challenges that we have, and the conversations around scale and sustainability. Thank you for your attention.
Thank you, Technical Director, Dr. Lai Jayula. Thank you very much once again. On behalf of TA Connect, we want to thank everybody for the commitment, and it's now time for tea break, and we have only 30 minutes to come back. Thank you.
in Nigeria. According to the 2021 National Immunization Coverage Survey, only 10% of children receive full immunization and 30% remain zero dose, completely unvaccinated. This leaves thousands of children vulnerable to life-threatening but preventable diseases. But change is happening. What keeps vaccines out of reach for these children? Supply challenges, long travel distances, and a lack of trust. Kano State has one of the lowest immunization rates in Nigeria. According to the 2021 National Immunization Coverage Survey, only 10% of children receive full immunization and 30% remain zero dose, completely unvaccinated. This leaves thousands of children vulnerable to life-threatening but preventable diseases. But change is happening. Kano State has one of the lowest immunization rates in Nigeria.
Please, for those who are outside, please let them join us, please. The time for tea break is off, I think. So we have only 2 minutes to commence the, yeah, okay. And after 2 minutes, we have a short documentary. So for those who are online, please, you keep staying, and we are going to continue very soon. Only a minute remains now. Time off, please. Please, let them come and join us, please. Please, doctor, call them, please. So now, ladies and gentlemen, we thank you all for safely return back to session. And now we are going to the multimedia, whereby we are we will have a short documentary that showcases the impact of this project and the achievement recorded. So please, the multimedia, please. For those who are online, please, we thank you all for your stay. We want you to keep staying as the program will commence now. And as I said, now we are going for a short documentary. by our multimedia, please. Are you ready? So for those who are online, please, we have a technical problem, and very soon we'll, continue. Please keep staying. So as we can see, the short documentary will play now, and it is just because we have a technical problem, and we are going to fix it, inshallah. You shouldn't mind, please. It's all along. So, the audio, please.
Kano State has one of the lowest immunization rates in Nigeria. According to the 2021 National Immunization Coverage Survey, only 10% of children receive full immunization and 30% remain zero dose, completely unvaccinated. This leaves thousands of preventable diseases. But change is happening. What keeps vaccines out of reach for these children? Supply challenges, long travel distances, and a lack of trust. And on the demand side, myths, misconceptions, and limited awareness discourage caregivers from seeking life-saving services.
Kamar iyaye musamman maza wasu zaki ga ba sa san allura. Da a ce da kanki zaki ringa zuwa guri haka yayi nisa, amma tun da dai ga guri ne ba za ki sha wahala ba, duk wani abu da zaki aikacen ki na gida zaki yi sa akan lokaci ba tare da kin yi gaggawa kin wannan samu. Idan aka duba a baya yadda aka fahimci ita cututtukan da suke damun yara da yawa saboda rashin ilimin me yake da ainihin cutar. Idan an zo da ake zanta a baka magani sai ka san abubuwan da suka kawo cutar da ba, kuma da idan an yi wannan magani din ma'ana an yi ita wannan allura da kafi din da yawa ba su san mahimmancin da ita wannan allura take da shi ba. Amma saboda yau da kullum abin da an yi wa wani kaga yayi lafiya da ya samu wannan cutar ba, an kuma yi wa wani shi ma bai da ya samu wannan cutar ba, wannan ta sa abin da mutane su The state is doing it to ensure that all vaccines are available, storage facilities are available, human resources are there, 100% available. But you may notice issue to do with cultural beliefs
norms of the society, and a lot of factors that bring Kano into this current situation. And the state is doing the best it can with support of supporting partners, ensuring that zero dose has drastically reduced.
We're fully aware of the magnitude of the problem. The challenge was that over 30% of children in Kano State had never received a single dose of life-saving vaccines. Now, from a leadership standpoint, our vision was clear. We needed to go beyond traditional interventions and adopt a solution that was both context-driven and system-sensitive.
To break these barriers, TA Connect, with support from the Pfizer Foundation, is working through the Kano State Primary Healthcare Management Board to deliver human-centered, community-based interventions that directly address both demand and supply-side challenges. In 2023, TA Connect, with funding from Pfizer Foundation's Global Health Innovation Grants GHIG7, implemented the accelerating vaccination uptake in children under 2 years in selected zero-dose LGAs in Kano State. What started as a rotavirus vaccination drive quickly evolved, guided by community input, ensuring children received comprehensive immunization in just one visit. The results were remarkable. More than 51,000 children reached in a single year across 1,244 outreach events. Missed vaccinations dropped by over 50%, thanks to a strategy that made immunization easier, more responsive, and more trusted. With the project's extension in 2024, TA Connect expanded into 6 additional GAs, adding a new layer: reproductive, maternal, newborn, and child health around services. These sessions, covering wash, nutrition, and child spacing, were co-designed with community input, ensuring they addressed real concerns in relatable ways.
As part of the deliberate attempts to use your data to iterate and refine your program, which is intentional again, by the way the program was designed, we realized that there was an opportunity to these caregivers. Not only that we were reaching much more numbers, but we knew that these women, when you look at what is called the continuum of the reproductive life cycle, these women also had all that healthcare services they had restrictions to, especially within the reproductive maternal area, which of course immunization is a component of. And so we saw it as an opportunity to reach there with much more valuable services that would help improve outcomes, improve the reproductive health program extension, their newborns, and that's what brought about to the wraparound services. The wraparound services was meant for us to integrate key reproductive and nutrition and wash services into the immunization program, making an integrated package. We know when we are all headed towards integration brings much more efficiency, provides much more value for money.
Data has been a game changer. Through real-time monitoring, TA Connect and the state government have made evidence-based decisions that improved coverage and deepened community trust, delivering tailored, high-quality care to the most underserved. Through dialogue and partnership, the initiative has built deep trust and strengthened relationships between caregivers and health providers, resulting in higher uptake and a stronger, more inclusive system.
We thought that we also reach there with family planning, counseling and services. We can reach there with watch services. Watch services is particularly important for them to be able to preserve the ideal status, not of themselves, but also of their newborns, and also other reproductive health services. So the background services speaks to integration. Integration speaks to more impactful services. It just speaks to cost efficiency, speaks to more value for money. So from the global perspective, it's more value for the funds that have been given. Actually, from the coming of the Single Connect, when we look at the state baseline, a lot of improvement was achieved, thereby ensuring that all the interventions provided are in place. Number one, before making it to the wider level, besides the rota, all routine organization contingents were brought in so that the good innovation both in phase one and also replicate in phase two.
This work aligns with national strategies championed by the National Primary Healthcare Development Agency, and it's paving the way for sustainable government-led ownership. The goal is clear: reduce the number of zero-dose children in Kano by 30% by 2025. Through innovation, human-centered design, and partnership, TA Connect is helping bridge the gap in immunization. One child, one caregiver, one community at a time.
Please, another big round of hand to TA Connect and other stakeholders, please. The next, after witnessing this short documentary, the next is the presentation on the project accomplishments, challenges, and lessons learned. Let me call the project coordinator for project overview, please.
Ladies and gentlemen, good afternoon. I stand on the existing protocols. I will be taking us through the project overview, accelerating vaccination uptake in children under 2 years in selected zero-dose LGAs in Kano State. Excuse me, please. So, yes, it's okay. We all know that mothers and children are very important people, and the health of mothers and children is also part of the marker of national development. So, children in sub-Saharan Africa continue to have the highest burden of mortality in the world, with current estimates showing 74 fatalities per 1,000 live births. And infant mortality is a global public health concern, especially in low and middle income countries. And these maternal deaths and the child deaths are preventable. And in response to that, the government of Nigeria, through the National Primary Healthcare Development Agency, has been trying to improve this immunization coverage through well-proven interventions. But however, despite these efforts, Kano State still faces some challenges with our immunization coverage, and data has shown that only 10% of children in the state are fully immunized. And it has been mentioned that Kano State also contributes 15 out of the 100 zero-dose LGAs that has been prioritized by the National Primary Healthcare Development Agency. So with this background, Pfizer Foundation funded TA Connect in partnership with the State Primary Healthcare Development Board to implement the project Accelerating Vaccination Coverage in Children under 2 years in selected 15 LGAs in Kano State. And following a notable success is an annual grant which commenced in the last year. This is the second phase. So the GHIG7 was the first phase, and there were notable successes during the initial phase. And based on that, there was a 1-year extension of the grant to this current grant, which is the GHIG8. So we can see that based on this success, it is well justifiable that the project, the GHIG7, Accelerating Vaccination Uptake, was solely focused on increasing the uptake of rotavirus vaccine. But that project not only significantly increased the coverage of rotavirus vaccine, it also showed a notable increase in the coverage of all the other antigens. And based on this success, the project was extended for an additional 1 year so that we would learn from the lessons learned and also scale up the effective strategies, as well as further reducing the burden of zero-dose LGAs in the state. This is why this project is justifiable. And the strategic goal of this project is to promote the uptake of vaccination in children under 2 years in the selected zero-dose LGAs by April 2025, and specifically to adopt a system-strengthening approach to address the barriers, the problems with immunization, both from the demand and the demand side and also the supply side. And importantly, to adopt a human-centered approach to co-create and implement interventions that will increase the uptake of immunization services. Lastly, we want to leverage on the interventions to address, to improve the maternal and newborn health while addressing the demand and supply side challenges. So we can see that using this human-centered design, those that are at the end users, we know that they are very, very important and they should be part and parcel of the intervention. So these are the innovative approaches that were used. Importantly, the human-centered design. We all know we are all primary healthcare workers. We know that any program that is done without community participation is bound to fail. And that is why the human-centered design stood out, where the end users are being involved right from the design to the implementation of the program. Another one is the integrated outreach. So, like I mentioned, it's not only limited to the rotavirus vaccine. If a child comes, any child that comes will be able to get the required antigen in a single visit. It's an integrated approach. And importantly, riding on the issue that we had data issues, we also know that data is very, very important in everything we do. So there is the element of data-driven decision-making in targeting those zero-dose LGAs. Data is used for decision-making. And lastly, there is the integrated wrap-around reproductive, maternal, newborn, and child health services. These children who benefit from these immunization services come along with their parents. So why not targeting the mothers too? So when the mothers are there, they also benefit from other reproductive services, including counseling for family planning, nutrition, as well as WASH, how to take care of themselves, their environment, and we all know that it is well related to their health status. So these are the intervention approaches. So let's look at
the key interventions that took place during this 1 year that the project was implemented. The project started with a co-creation meeting. The screen. It's obscuring the... So the project began with a co-creation workshop where a meeting was held to introduce the second phase of the Pfizer project. And the meeting was attended by key stakeholders, including from the Kano State Primary Healthcare Management Board and the CERIC leadership, also members from TA Connect, and also partner agencies. At that meeting, that was when the lessons learned from the previous phase were discussed, and a human-centered design was adopted for the subsequent phase, and 15 LGAs for intervention were selected. Initially, the LGAs with high burden, low coverage from some of the LGAs, and with the permission, I would like to move closer. Apologies, please. So, together with the Kano State Primary Healthcare Management Board and some partner organizations, 15 LGAs were selected, and 6 LGAs with high burden and low coverage of immunization in phase 1. And these LGAs include Dawakin Kudu, Tofa, Rano, Garumalam, Sanyawa, Minjibir, and Wudu, with also 9 zero-dose LGAs: Iru, Bebeji, Ungogo, Tudunwada, Dambata, Tarauni, Dawakin Kudu, Nasarawa, and Kumbotso LGAs. So, these facilities were selected based on a laid-down criteria, including high-density population settlements, rapidly emerging new settlements, security levels in some settlements, and then the coverage rates of the key antigens of intervention: measles 1, measles 2, penta 3, IPV, and rota 3 coverage rates. Based on this, these LGAs were carefully selected in order to get value for money of the project. So the phase 1 LGAs, like I have already mentioned, we started with 6 LGAs. Phase 2 LGAs include Kiru, Bebeji, Tungogo, Tudunwada, Dambata, and Taroni. And then 3 LGAs were subsequently added, including Dawakin Kudu, Nasarawa, and Kumbuzo. So 15 LGAs, 90 communities were supported in this project. The subsequent activity following the selection of these LGAs is to keep people abreast with the information and the skills they need to start up this program. As such, a series of orientations were held, including orientation of state, LGA, and health facility team on the integration of on RI intensification activities. In that training, there was 285 people in attendance from both the zone and the state and zonal health officials, as well as partners. And it was successfully conducted with the successes and challenges of immunization in the state carefully discussed. And all stakeholders enlisted their commitments in ensuring the success of the project. This was followed by advocacy and sensitization of community gatekeepers across those 15 LGs. It cuts across traditional, religious leaders, DBAs, VCMs, chiefs agents, WDCs, all to gain the cooperation and maximum cooperation of those stakeholders. And 200 community leaders were in attendance, and issues surrounding the vaccination, barriers, and facilitators of vaccination were discussed, and we really demonstrated clear enthusiasm towards supporting the project objectives. Some other interventions include community dialogue and compound meetings, which were conducted across those 15 LGAs. This is to increase the demand for vaccination services. This serves as an avenue where people will be, awareness will be created, and then people will have the opportunity to make informed decisions to uptake those services for the betterment of their community. And these are usually attended by the either males or females during the compound meetings, and they are usually sessions are being facilitated by LIOs, health educators, caregivers are in attendance, and usually discussions center around the importance of childhood vaccination, barriers, and then facilitators, and then also leveraging on those sessions to discuss on other wraparound services, including the wash, bed spacing, and nutrition. Another key intervention is conduct of outreach services, outreach immunization sessions, and this is to The aim of these outreach sessions is to increase the immunization coverage and other RMNCH plus N services. And the target population is usually children under 2 years and their caregivers who benefit from the RAMCA wraparound services. And like I said, it's an integrated approach where all antigens are being provided to children in a single visit. In order to improve the quality of data, sessions, monthly data validation meetings are usually conducted to ensure accuracy, completeness, and reliability of data that is collected during these immunization services to inform decision making. And it's usually conducted by the LGM M&E officers with the facility staff and in the attendance of TA Connect staff. Most data entries during data validation meetings, it has shown that most of these data were complete, and largely this is due to regular on-site supervision and feedback from those facility staff. However, some LGAs reported delays in submission of tally sheets by the vaccination teams, and it is for that reason there is continued need for continuous monitoring and supervision of those teams to maintain the quality of data and improve the timeliness of data submission. There is also quarterly field supportive supervision by the state officials, zonal officials, and LGO officials, all in an effort to improve the quality of data for improved decision making. There was also a co-creation meeting with stakeholders regarding the RAMCA wraparound services integration. What started as a clearly immunization program became more integrated, where those services, counseling services, were also offered to these mothers about child spacing, nutrition, as well as wash services. In order to facilitate this RAMCA wraparound services, there was a review and development of IEC materials for the wraparound services, where comprehensive, short, and direct messages were summarized in the form of a flip book, where those healthcare workers will provide the requisite and necessary information to those healthcare workers who will be used during those outreaches to facilitate those sessions. After the development of those IEC materials, there was an orientation of the healthcare workers, reorientation, so that they will be abreast with the way the tool is, and then to also make it easier for them to use while offering their services. In that orientation session, 90 vaccinators and the recorders were trained, including their M&E officers. And this was followed by an immediate integration of the services into the integrated outreach services. At this point, I would like to call on Sagir to give us the results of these interventions. Thank you very much.
Well, ladies and gentlemen, permit me to stand on the existing protocol. So the outcome of all this effort made by the state and the development partner, that is TO Connect, is going to be presented by me. So 15 LGAs were selected for this intervention, out of which 10 are 0 dose. Learning from the previous phase of implementation, 9 LGAs were selected during the previous phase. So looking at the nature of the state have the high burden of 0 dose. Adding 6 LGAs from the 0 dose LGAs in the state to the 9, making it 15, and the careful selection of the facilities based on the record, the data from the state show that those facilities, 90 selected facilities, have the high burden of 0 dose, and also high burden LGAs were added. So categorically, if you look at the data, 11,348 children were reached using the additional outreach session. The outreach session that was initiated does not replace the initial normal outreach and peak session that the state is conducting, but rather it is complementing. It's an additional outreach that we conduct to capture the remaining children that were not reached during the normal peaks and outreach session that the facilities are conducting. So out of this result that we achieved, 54% of those children that were reached are female, looking at the data. Not moving. So this is the granular result of what has happened during the 9-month implementation period. The project is implemented in 1 year, but the real implementation of the outreach was conducted in for 9 months. So this is the result. Looking at the data, you can see that the state could have achieved 86% coverage in Bebeji, if not for this intervention. But with the additional outreach that is supported, they were able to reach 110% coverage in Bebeji LGA. Looking at the Woodhill, you can see that 96%, but the trend showed that 85% coverage was achieved during this implementation phase, which, if not for the project, they will be able to only achieve 52%. This speaks about entry into immunization system. You know, for the 0 dose, we are targeting the entry into the immunization session. The ones that are not reached, we're able to capture and immunize those children in selected communities. This marks the entry into the immunization system. That is Penta 1. For the Penta 3, it marks retention of those children. We are able to retain those children that we were able to get in Penta 1, so we are able to retain and have this significant progress. If you look at the data, it is showing that in Bebeji, if not for the program, if not for the additional outreach, they will be able to only have 87% coverage. But with the additional outreach that was conducted, we're able to get 106% coverage. The result, if you look at the result, is showing a significant improve in immunization coverage, more in rural LGS. If you look at Woodhill, it's the one with the highest number or highest percentage of improvement in immunization coverage, which if not for the additional outreach, it showed that the LGA will be left behind in terms of immunization coverage. But if you look at Nasarawa LGA, being the metropolitan LGA, it's one of the metropolitan LGA, it will be difficult for you to walk 2 kilometers without having access to facility. So the result showed that in metropolitan LGAs, the result, the outcome is not that as good as the one in the rural LGAs. So notably, for rota that is used to prevent diarrhea in children, looking at it, despite the fact that the state has battled with the shortage of this rota vaccine, but we are able to support the state in having almost 92% coverage in Bebeji, and in Woodhill, you can see that we were able to get 88%. This showed that if not for the additional outreach, the children in Woodhill will suffer more on these diarrhea cases. But with this additional outreach that complement it really helps in getting the remaining children that were not vaccinated during the normal session. So this cut across the Rota 2 and also a Rota 3. That speaks of retention. Those children, looking at the data in the Rota 3, during the previous implementation phase, it is Rota-only vaccines. But with this integration of the remaining antigen, during this phase, all antigens were incorporated into the program. And the one that we are tracking, we track only Rota, measles, and Penta. So you can see that we are able to reach 100% in some LGS because during the previous phase, a lot of children has entered into the immunization sessions. But when we came to implement during this second phase, we were able to complement or complete the remaining children that entered into the immunization system during the previous phase. So the state, learning from the experience or from the previous record, it deems fit that measles be incorporated into the immunization session because it marks the completion of routine immunization of children. So the results showed that most of the LGS were able to reach more than 50% using the additional outreach session. This marks the completeness of immunization of children before they reach their first birthday. So this is the contribution. The state continued to implement routine fixed and outreach session. But looking at this data, the additional outreach that was implemented was able to contribute to 27% coverage in the state for Penta 1. If you look at the trend, you can see that consistently the result is showing that above 25% were gotten during this implementation phase. So this is the contribution for the program to contribute to 1/4 of the targeted children vaccinated. So this marks an achievement as well. So this is the breakdown, the LGS. The program is implemented in 15 selected LGS. This is granular detail of what the LGS that contributed to that achievement that was recorded. Looking at this data, you can see that the WUDL still remain the largest or highest beneficiary of this additional outreach. This is for Penta, for comparison of Penta and Penta 3 and Rota 3 as well. Good. So this is the contribution of measles. If we look at the measles contribution of the additional outreach, looking at, I keep on mentioning WUDL because WUDL, the terrain in WUDL and demand for services, most people in WUDL don't come out for routine immunization. But with this shows that there is need to intensify outreach in remote, rural areas, especially this WUDL. But if you look at Nasarawa and Taron, you can see that the result is not showing that significant improve because of the nature of the place. So moving forward, the program does not only target 1-year children. Most children that started vaccination and were not able to complete before their first year, before the first birthday, the program was able to map those children. And this is the result. If you look at Rota, still WUDL remain the highest beneficiary of this intervention for above 1 year, because looking at that, most children or most caregivers are in need of those immunization services. But because of the terrain, the distance from their homes to the health facility, it shows that there is need to improve outreach services. So this is the number of children captured or that receive measles too. The booster dose of measles, if you look at the trend, you can see that a lot of children received measles second dose. That will significantly help the state in attaining for children to have the herd immunity. So for the contribution of, for the 12 to 23 month, that is under 2 years, 1 to 2 years children, as we can see that this is the contribution of the state in percentage. For Rota 1 and Rota 2, for Rota, you can see that the contribution is above 50% compared to Penta and measles, because as I rightly mentioned that during the previous phase, a lot of children received Rota 1, Rota 2 during the, before the close of the previous phase. But coming off with this, during this second phase, we are able to move off the remaining children that started and have not completed. So, and for the wrap-around services, integration of those wrap-around services, the RAMCA, WASH, healthy spacing of children, we are able to implement only for 3 months. But this showed that if you look at how the data is going from February to April, in February, only 2,000 women were reached for those WASH services. But moving forward, women realized that there is need for that orientation. So they keep on coming. If you look at the data, it keeps increasing from 2,000 to 4,000, and before the close of the implementation, we're able to mobilize and educate 5,367 women in April. So after giving them health talk, there's need for referral as well. So if they need the services, the program refer the caregivers to health facility to access those services. It does not stop on only educating them. There is need to refer them as appropriate and follow up with the facilities to ensure that all the commodities for those services were available. So I think this is the
Yes. Oh, put it down a bit. Put it down a bit. Thank you so much. Thank you very much, Sajid, for taking us through the project results. So the project was not without some challenges. The few challenges that were encountered during the program basically revolves around stock out of vaccines, especially the Rota vaccine. And this was mitigated through data-driven redistribution of vaccines to where they are being needed. Initially, there was also hesitancy and poor acceptance of immunization services. However, with the community engagement and sensitization and mobilization efforts, we're gradually seeing a reversal of those trends, and people were really accepting those services. Another challenge was low turnout during outreach services, especially due to economic activities, like during rainy season at the beginning of the program. So sometimes if there are outreach services that are being run during market days or when they are going to the farm, there is low turnout. And like I said, since this program really employed a human-centered design, it was mitigated through community involvement to sit down with those members of the communities to plan on the date, time, and necessary venues for conduct of those integrated outreaches. So what did we learn? That wraparound RAMCA services facilitated the integration and efficiency as caregivers were reached with vital interventions, information and education that was used to improve access to those RAMCA services. It is also worthy to note that integration emerged as a cost-efficient and sustainable approach. And the use of real-time data through mobile reporting tools significantly improved responsiveness and accountability in service delivery. The following recommendations are being put forward. Sustainability of existing community-level mobilization, community dialogues, and demand creation efforts should be put in place. There should also be scale-up of the project. These integrated approaches should be implemented in more zero-dose LGEs. This is with the hope that it will contribute in reducing the adverse maternal and child health outcomes. Thank you very much.
Thank you, Dr. Nafisa. Please, once again, put your hands together for Dr. Nafisa. For our critical stakeholders in this room and our friends online, we thank you sincerely for staying with us through this entire presentation and through this entire event. We thank you for your patience, and we also appreciate the fact that you deem it fit to be part of this conversation to fight zero dose, not just in Kano State, in Nigeria, and even beyond. Now, quickly, we are moving into a very, very interesting session. We are moving into an interactive session. We want a two-way dialogue. Well, we've been speaking, we've been making presentations, we've heard from a couple of dignitaries in the room. We've equally made our presentation, speaking to our approach, what we've done with this intervention in the last couple of months or 1 year, so to speak. So to our valued partners, our stakeholders in the room, and our friends online, would like you to join this conversation. And the starting point for me, the starting point, for this is to actually reflect, basically, on what actually stood out for you, the most from this implementation or from this intervention. I have the second microphone. Can I have the second microphone, please? Okay, yes, Falila, you're with the second microphone, so you help me with that. So we'd like to hear from our stakeholders in the room. The states, our stakeholders from the states are here. They were all part of this whole process. This program was implemented by TA Connect in partnership with the Kano State Primary Healthcare Management Board. And of course, it has been said time and again that our approach to this intervention was anchored on human-centered principles. And again, here in this room, we are still going to ensure that everybody is part of the conversation because it's going to be a two-way thing. So now the microphone is here. Just tell us what actually stood out the most for you as part of this intervention, or if you actually have anything you have to say about what you've done differently with interventions like this. We are equally happy to learn. And even if it is a criticism, even if there's something you pick out of our presentation and if you want to mention it, the floor is open so that we all make this conversation very, very open and robust. So I'll now invite Falila to come forward with the microphone. You can just start by indicating. Those online could equally indicate by raising up their hand. We have one of our colleagues who is manning that platform. You can equally drop a chat as well, or a question if you have your comments, and we are willing to take all of them as we steer through this conversation. So please, we already have a hand here. Yes, please, Falilat. Yeah.
Okay, thank you very much. My name is Dr. Farao Abdusalam. I'm representing the Director Medical Service from State Primary Healthcare Management Board. Mine is to say thank you for all the people that have contributed towards this success. For me, the most important thing that catch my mind is the fact that they use the human-centered design. Because if you look at it, our problem mainly is, like they have highlighted in the challenges, is that people not actually accepting these vaccines initially, especially in the rural areas. So that approach was a good one. And if we are to maintain this, definitely we are going to record more success. My only concern is how are we going to ensure that this is sustained going forward? Thank you very much.
Interesting question. Please put your hands together for him. Issue of sustainability. Yes, we have another hand here. Falilat.
Good afternoon, everyone.
Good afternoon.
Mine is in line with what Dr. Farah has rightly mentioned. And secondly, let me directly go around, wrap around activities that came at the tail end of this activity. That is the issue of integration, bringing in wash services, nutrition, and family planning, and other important activities that we think if they can timely commence together, definitely is for the benefit of the state. So lastly, it's just a prayer for a scale-up so that we can begin with this key intervention. Thank you.
Thank you very much. Let the conversation continue. Yes, we have another hand in the room.
Thank you, and kudos to TO Connect. This is a great achievement, and I think you're setting a precedence that there's that need for the state to really build on. I'm happy to hear the presentation, and of course, already somebody have mentioned the human-centered approach is a very key. We need to also emphasize on the integration component where you don't just have to come for the child, but of course the mother also. So integration is very key. For us to achieve the universal health, certainly the aspect of data-driven. Whatever you're going to do, you have to just use the data to make your decisions. And I think this is one key approach that we need to really make sure that the state take ownership of this for us to really progress. I mean, whatever you're going to initiate, make sure that it is linked to evidence-based data that you can be able to. But however, I have a concern. Under the challenges, we got to hear the issue of stock out. So the question is, why stock out? We need to really see situations where these antigens are available. I mean, the vaccine should be available, so why should we have stock out as a challenge? How do we go about addressing the aspect of stock outs? It is just, more of like a pilot, looking at how large Kano is. If we are just having this intervention in some few LGS, we're having 44 LGS. So looking at the impact that this intervention is going to bring, how do we sustain this intervention? So it's left to the state to see, and of course partners that are also supporting. It's one thing for TO Connect to showcase this, that this is our own contribution. But then from there, how do we go about sustaining this intervention and to see to the success of our own desire, especially at the state? These are my contributions.
Thank you, thank you. Yes, Hafiz.
Yeah, good afternoon, everyone. Hafiz Abdullahi, I work with Chai here in Kano. I think what stood out for me is the results part where we showcase the data. If you can see, Nasarawa is an urban LGA, and like most of the other urban LGAs where we implemented this project is where we are having the lowest coverage. So for me, the question is, why are we having this? Which means we need to do something differently. So is it because it's an urban LGA, and is it more of a demand issue rather than a supply problem? Because in Nasarawa, I don't think there is any settlement that is remote, that is beyond the distance to warrant conduct of outreach session. So, but here we are seeing 32%, 36% uptake for is it Penta 1 or Penta 3, I can't remember exactly. So, but what I'm trying to say is that we as partners that are working within the immunization space, we need to put our heads together to really think around what can we do differently to actually change these results that we are seeing in urban LGAs like Nasarawa, where we are not seeing a good results there. Thank you.
Please put your hands together. Thank you. Any other person from the room? Do we have anyone online? Okay, our online participants, we thank you, and we are still sifting through to see if you have any contribution. But I mean, it is open for everyone to actually provide needed response to some of the questions that were raised in the course of the interactive session. However, I actually jotted a couple of things. I mean, even as we reflect on the achievement of this intervention, one critical question we also have been asking ourselves a question of sustainability. How do we sustain this intervention even beyond, the life of this program? Well, we've seen the value of integrated services like the PM rightly mentioned. We've seen the value of community engagement, supportive supervision, and of course, our human-centered design approach as well. So now again, we want to invite everyone in the room, especially our colleagues from the government, especially our colleagues from the government sector and our partners who are in the room, even, our community groups as well, if you like, to share your thoughts on the following. Share your thoughts on what structures or systems can we strengthen to sustain this momentum. We want our government people to actually speak to this. What structure or systems moving forward can we strengthen to sustain this momentum? And we also are happy to have, community leaders here, respected community leaders who like to know what roles, the LGAs, the communities, and all partners can also play post-project, post-implementation. This is also key. And are there some low-cost, high-impact component that we should prioritize for scale-up? All of these conversations are some of the conversations we should be having. So, the microphone should come close to some of our government partners in the room. We'd like to know what structures or systems can we strengthen moving forward, to sustain this kind of intervention. Yes, is there anyone? Okay.
Thank you. Good morning, all. Or good afternoon. Mine, we have a lot of government structures that was supposed to be, in order to sustain these activities, that we have structures like WDC structures, which are available in every ward and in every community. So these structures are working freely without a payment. And then it's a truly community structure which support demand creation for services at the community level and report anything that is worrying the communities. Then another structure that we supposed to strengthen on this issue is the issue of the traditional and regional institutions. In Kano State, traditional and regional institutions play a vital role in each program that want to be sustained. These people with their own buy-in, the activity will be sustained because they are doing it freely and with a good mind in order to help and improve the well-being of our communities. Thank you.
Thank you very much. These are all fundamental questions, but we intend to have this conversation in a much more robust manner, and that is why if you look at your agenda, you actually realize that we have a panel session. And in this panel session, we are going to be exploring most of these questions, that I had raised, in the course of my summation of your submissions from our interactive session. And to anchor and steer this panel session, please join me to welcome Dr. Jessica Ango, our technical manager, TA Connect. Put your hands together for her, please. Please, can you help me with this so that we can, thank you.
Okay, thank you very much for that beautiful welcome. Permit me to stand on the already existing protocol. Yes, so I was really happy when they were asking for the interaction, and then somebody already started asking the question on sustainability. And that brings us to this session, which is going to be a panel discussion. And we really want to go deep to understand and find out innovative, sustainable pathways to ensure that this intervention is being maintained. I think it's a very important discussion that we need to have. And I'm going to anchor this session, and we have seasoned stakeholders that are going to join and lead in this conversation. So I'll just go straight to it and introduce our panelists. We have 4 panelists for this session. The first panelist is Dr. Sharif Yahaya Musa. He is the Director, Disease Control and Immunization in Kano State Primary Healthcare Management Board. He is a seasoned medical professional with vast experience working in the field of immunization, disease surveillance, and medical services. Before his role as the director, he served in different capacities, including the state immunization officer, so you can see he's really positioned for this. He also served as the Director of Medical Services. So please give a resounding welcome to Dr. Sharif. You're welcome, sir. Please, louder. Let's encourage them. Thank you very much. Our next panelist is not a stranger to all of you. He is Awal Idris, the project manager for the State Emergency Routine Immunization Coordination Center, SERIC. He is a community health professional with over 13 years' experience working in the field of primary health care. Prior to his position as a PM SERIC, he served diligently in the field, including working as the routine immunization team lead. He has vast knowledge in coordinating routine immunization and supplementary immunization campaigns in Kano State. Please, let's welcome him to the stage. Thank you, sir. So like I told you, we have a vast array of stakeholders. Our third stakeholder is from the community where we work. Without the community, these interventions are useless. And so we have with us Aminu Ilyasu Abdelkader. Aminu Ilyasu Abdelkader is a distinguished community leader in Kumbosu, which is one of the zero-dose LGAs. He is an advocate for education and community development with a strong background in Hausa and Islamic studies. He has experience both in the formal and the informal sector. He is deeply involved in grassroots education and outreach, and his work is driven by deep commitment to empowering communities through education and moral guidance. Please, let's welcome him. He's already up here. You're welcome, sir. Last but not the least is Baba Gana Mohammed. He is currently the routine immunization focal person for WHO here in Kano. He is a seasoned public health professional with over 17 years experience in immunization, disease surveillance, and health system strengthening. Prior to this, he has served as multiple roles, including the national facilitator and cluster consultant here in Kano. He's a national facilitator in Kano and served as a cluster consultant in Taraba State. Over the years, he has led strategic initiatives, including including integrated strategies for disease surveillance, supplementary immunization activities, and he continues to work to strengthen primary health care delivery and improving immunization coverage. Please, you're welcome, sir. Thank you. Please, let's give a big round of applause to the panelists. So I'll go and join them, and we'll have this discussion. Thank you. Okay, so back to the audience. Earlier on, we had an interactive session. Can you hear me? All right, thank you very much. Right, so today has been very interesting, even for me as part of the team. Hearing the presentations, we watched a lovely documentary showcasing the work that we've done. We've seen data to prove that there was success and there were gains. Starting from Rota vaccine, which we now evolved to giving other antigens, and more recently, the wraparound services, which worked to integrate the services that we're providing, the immunization services that we're providing, so that the women, the caregivers, and their children can have access to these services. And the results speak for themselves.
Right, so with us here, we have different stakeholders. I would like to start with the director. From your profile, we're aware you've really worked in this space. And the question is, we want to sustain these gains. A lot of times we have lots of projects, they have lots of successes like this one, and then later on, we're faced with going back to where we were, or worse, going worse than it was. So we want to ensure that these gains that we have achieved are being sustained. So I would like to ask you, as a key stakeholder working in the government, who is among those of the people that make decisions in the government, what have the government done to institutionalize and finance integrated services regarding routine immunization, particularly in zero-dose LGAs? So what I would like you to do is to share with us what the government is doing, what they have put in place. Are there any lessons that you've learned or you're learning? And are there any challenges with implementing these interventions? Thank you, sir.
Thank you very much. Let me thank the facilitators of this discussion, or panel discussion. For routine immunization, let me go by line of history. We had an MOU with two partner organizations. The government came in to be the third partner. That MOU is just to support or to look at the activities of routine immunization generally. And then we formed a lot of structures that will ensure the coordination of this routine immunization. The contribution of those partners were timely, actually. We did the first year, we did the second year, the third year, and the fifth year. There was 1 year extension that happened. And the MOU ended in 2017, 2016, somewhere around that time. And since then, we know Kano State government has taken the leadership or the responsibility to ensure the funding of RI. When I say the funding of RI services, it will fund the distribution, the pushing of vaccine to the last mile. And let me remind you, Kano is the first state to introduce the push system in Nigeria. And up to today, Kano state government is providing funds to ensure that we deliver vaccines to the last mile. And this is happening in Kano State. Number two, we ensure that money or funds are available in all the facilities that are conducting routine immunization. That we identified in all the 484 wards in Kano an Apex facility. And we ensure government provided the solar refrigerator in all the wards, in all the 484 political wards in Kano. And this is happening in Kano. All the 484 political wards had their solar refrigerator in a facility identified as an Apex facility. And this Apex facility will ensure that it distributes vaccine to the other facilities within the ward. This is all have been taken care by the Kano State government. Other activities that are supposed to happen to ensure that routine immunization is happening include the outreach. We have been discussing the outreach, the funding of outreach, and it's happening. And we are even looking at how do we modify to ensure the current realities in Nigeria so that we sustain, we continue with the outreach. There are a lot of other services that Kano State government funds, and we ensure that we get the funds and we ensure those services are happening. Of course, there are a lot of partners that support Kano State government. Still now, we have a lot of partners that support Kano State government. So in terms of sustainability, we have a budget line for RI in Kano State government budget that will ensure funds continue to come and continue to fund all the structures, the services that happens as far as routine immunization services is concerned in Kano. And one area that I always give example to is the delivery of vaccine. We never fail to deliver vaccine in Kano. And that system is still in place, and we continue to apply that system, and we continue to supply the vaccines in all the facilities that conduct routine immunization in Kano State. I just want to deviate a little before I come back. I have seen a discussion on stock out. Yes, I've seen a discussion on stock out. There are a lot of discussion on stock out around the corner. People may not know. And we have a lot of channels to communicate when you have stock out. In Kano, is a service provider is at fault when he raises his flag on the day of activity that you will see, I have a stock out. Yes, it's not acceptable. And that is not done in Kano, that a service provider will raise his flag on the day of the activity that you see. That is one of the source of the, what do we call? When mothers come and they never come again. Not missed opportunity. It's another name.
Attrition or defaulting?
Is it defaulting?
Lost to follow up, maybe?
Is it? It's okay. Defaulting. Whatever you see, that thing. Because you gather women, you gather clients, they are waiting for you. You immediately come to the facility, and just what you tell them is, there is no vaccine. Come back next week. You are almost saying, don't come back again. Yeah. They are not coming back for that activity. Especially at this time of, what do I call it? Economic. Yes. Yes, somebody say that. Yeah. They are coming from far, from remote areas. You don't know how they get even money to transport themselves. You are now seeing. So we don't accept that in Kano to raise a flag on the day of activity. What you usually do is you know the channels, how to communicate once you need those vaccines. You raise your flag, don't allow your vaccine to say finished. When they are about to finish, raise your flag. And you know where to communicate, where to channel your information that I need vaccine. It's not the state that you communicate. Don't forget, we have 6 primary healthcare zones in Kano. And those zones are taking the responsibility to deliver vaccine to the facilities. And we usually keep 25% buffer in all the local governments. So that, why are we keeping these vaccines at a local government, at the Apex facility, even at the zone? Is to respond to in between the rounds, so that there should not be any stock out before any either fixed or outreach activity. I just want to tell you that we place all these issues so that we minimize. I cannot say 100% we don't have stock out, but we try to minimize the stock out. We try to minimize the stock out once we follow these channels of communication. Once we rightly communicate, we are going to minimize the stock out. Sometimes a facility will have a stock out. You don't rightly mention or report that stock out early. So there are so many wrong communications in the facilities to where they're supposed. One, they're supposed to communicate. They are not supposed to go and pick vaccines. money, foiling is available so that that Apex facility will respond to that facility in need of vaccine. Because Kano State government is taking responsibility of all this movement. So that is why I said sustainability for this activity, we don't have much problem actually. Government is committed, partners with us are committed, so that all this activity that has been projected or presented to us, we look at it holistically at the CEREC, and we discuss how to sustain and how to implement other activities that is not even mentioned here. But I think we have the structures that will ensure we sustain this. For me, the commitment of government is number one. Kano State government is committed actually for this routine immunization. It has been funding and it will continue to fund this activity. We have a lot of partners that support this activity in Kano State and continue to get the partners that will be supporting this activity. A lot of partners come to Kano, especially for this zero-dose activity. And we're looking to map these partners, to look at their activities so that we harmonize all the activities of the partners, because government usually is on the driving seat and will ensure that we utilize all this activity from the partner agencies so that activity will sustain and continue to run in Kano, especially this routine immunization. Thank you very much.
Thank you so much, sir, for that insight. It's good to know that Kano is working to ensure sustainability. So right on to some of the things you mentioned. I'll move to the PM, CEREC. He has talked from, let me say, maybe a policy point of view. But I would like to hear from you as an implementer, because you're a field person. You're the one that goes down to where the people are. What effective implementation approaches have we put in place? Particularly, he mentioned trying to avoid missed opportunities for caregivers and their children. So please, could you highlight for us what implementation approaches are in place?
So thank you for this wonderful opportunity. When you talk of implementation strategy, what really comes into my mind first was the strategy put in place for Kano. Not only Kano. You know, there are 3 identified strategies that need to be implemented, which include peak sessions conduct, that is, clients are expected to visit facilities within the range of less than 2 kilometers, right? Then for those that goes beyond 2 to 5 kilometers are expected to be visited, to benefit from what is called conduct of outreach, not even the only outreach, quality outreach. And for those that reside within the kilometer of more than 5 to 10 kilometers are expected to also be visited, benefiting from a service called an outreach services, isn't it? So, and I believe the issue of zero dose, if these 3 strategies can be adopted, well planned, implemented, definitely the issue of zero dose in the state can be a history, right? The state is really up and doing. Human resources are there available across all the levels. Vaccines, as mentioned by the first speaker, is 100% available, but I believe there are some, at times, that issue of bundling become an issue in the state. But the ideal situation, number of doses issued should tally with the number of devices, but that doesn't stop us from doing what is expected, looking at the commitment of the state generally. So once human resources are available, services are also expected to happen as planned, right? And we have so many mechanisms to track the quality conduct of these services, especially with the coming of some supporting partners, thereby ensuring that all planned peaks and outreach are duly conducted and in the designated expected place for that activity to happen. Not unlike the previous practice that facility A are expected to conduct an outreach here, isn't it? But they can conduct a services within the premises of a facility during the day of outreach, putting in mind that they cannot be tracked. But this is unusual, isn't it? So with the coming of partners, definitely a lot is really happening so as to track whether these strategies are, one, happening, and if they are happening, is it of high quality? What needs to be addressed, isn't it? So if these activities are also happening, for the non-implementing LGS, how can we pass an information to them that this is how you are expected to do any activity you plan? So by and large, I think these three strategies, if can really be implemented as how they are expected, will be the solution of addressing our zero-dose issues in the state. Thank you, and over.
Okay. Thank you, sir. So please, there's something you mentioned, and I just wanted to add another question to it. So you said you have these strategies in place, and the healthcare workers are aware that they're supposed to do this. Are there things that have been put in place to ensure accountability? So when we find healthcare workers who have been fully equipped, we have commodities available, we have all they need to carry out these activities, and they are still not pulling through. Are there accountable measures that are put in to do? And if they don't, they would.
Thank you. Really, every activity is designed to be implemented based on the standard operation procedures, right? And service providers are fully aware that once an accountability measure is not put in place, do not expect what you are expected to get. That is why we emphasize on one, proper supervision. Any activity you design, make sure that supervision is intact. And for that to happen, every state supervisor, LGA supervisor, ward supervisors are also tasked to do their own mandate. Every LGA team member is attached to a peak session or outreach team so that he or she can supervise and ensure that what is designed to happen is what is really happening. And in a situation whereby, you know, the opposite happens to be what was recorded, you know, there are some mechanism that was put in place, not just to transfer a health worker. If you transfer garbage from A to C, so expect the same garbage will also be happening there, isn't it? So a lot of things tied to accountability is really put in place to ensure that we all stand on our feet.
Okay, thank you so much for that insight, sir.
Can I add something?
Yeah, please.
Just 1-2 minutes. I think in the beginning I've said Kano is being divided into levels. We have state, zone, PSC, and even the ward level. And this is to ensure that supervision is happening and accountability measures are taken or are followed. The immediate people to supervise these service providers at the facility are the LGE, local government, because they are closer to the facility. And we have zonal level that will ensure that things go well at the local government level. But that doesn't stop them from going further to the facility to ensure things are happening. And all we have to ensure accountability are being followed. After the zone, we have the state, and that will be the last resort. And at all these levels, supervisions are happening. Supervisions happens maybe from the state, will go to the zone, LG, and facility. It doesn't mean if you are going from the state, you will not go to the facility to supervise. No. You need to go to the facility and ensure things are happening. And we need to ensure that accountability things are. So that every level need a report for them to take action. If things are not going well, report immediately, action will be taken according to the civil service rule. Thank you very much.
Good to know. Thank you for the work that you're doing. So, like we mentioned, without the communities, then everything that we're doing is
bound to fail.
Yes. So, Malam Aminu, thank you for joining us here from Kumbotsu. You're someone that is a community advocate. You're very passionate about working with people in the community. And so I just want to get your own perspective. We find out that sometimes these interventions are available. However, people still do not want to access the services. So as someone working in the community, could you please tell me some of the factors that influence immunization uptake? And not just immunization uptake, you're aware that we also extended our services to be integrated to make it cost effective. So other than immunization services, what factors influence both acceptance of immunization services and other reproductive, maternal, newborn, and child health services in the community? Thank you.
Thank you very much. I would like to seek your permission if there is you can allow me to talk in Hausa so that somebody will interpret. I'm sorry for that.
True community person.
Yes, representing my community. So as you asked me that, what are the factors influencing the uptake of immunization and the reproductive, maternal, newborn, and child health services in our community level? Honestly, it's quite difficult. Okay, so, ya sha bamban, assalamu alaikum, afwan. Kamar yadda tambayar ta nuna shine, kamar waɗanne abubuwa ne suke sawa al'umma ba sa karɓar wannan allurar rigakafi a yankunansu, ko kuma wani abu ne yake kamar jawo hankulansu su dinga zuwa suna karɓar allurar rigakafin yau da kullum. So haƙiƙanin gaskiya, community ya sha bamban da wani community ɗin. Kamar yadda kuka bayani cewar ana aiki da local government guda 15 a jihar Kano, na tabbatar idan aka bincika za a samu abin da wannan local government take da matsala ba lalle irin wannan local government din take da matsala ba. To amma kamar mu a yankunan mu na Kumbotso local government, babban abin da yake kawo haka shine akwai rashin fahimtar su waɗannan alluran rigakafin yau da kullum ɗin ga wasu daga cikin al'umma. Wannan yana kawowa idan an zo za a yi wannan allurar musamman ta outreach ɗin ko kuma ta wadda ake yi a asibiti, za ka samu mutane ba sa ba da goyon baya su je wannan guri domin su karɓi wannan allurar yau da kullum da ake yi. Abu na biyu wanda yana iya jawowa haka ɗin mutane su ƙi zuwa shine akwai guraben da suke da ɗan tazara a tsakanin su da gurin da ake yin wannan allurar rigakafi, musamman kamar za a ce akwai distance na gurin da suke zaune da kuma gurin da ake ba da ita wannan allura. So amma alhamdulillah a ƙarƙashin wannan an samu sauƙi ta yadda ake zuwa yankunan namu cikin unguwanni, musamman waɗanda suke da nesa da asibiti, ana zuwa har gida ana ba su wannan abin. Amma abin da yake faruwa na matsala a nan shine akwai rashin sanarwa da wuri yayin da za a zo wannan outreach ɗin. So shi ma yana janyewa idan an zo ba za a samu 100% abubuwan da ake so ba, saboda wasu matayen ba za su fito ba sai sun sanar da mazajen su cewar za a zo allurar rigakafi yau ko gobe ko jibin misali. To mazajen sun riga sun fita wasu uzurrukan nasu, su kuma wa'annan masu allura sun zo, to ba za su fita su je su karɓa saboda ba su gaya wa mazajen su ba. Wasu kuma ba su da hanyoyin sadarwa musamman telefon ko wani abu da za su iya gaya wa mazajen su cewar an zo yin allurar rigakafi za mu je mu karɓa. So wannan sai ta kawo feluwa cewar ba za a sami karɓar wannan abu yadda ya dace ba. Abu na uku a wannan abin da yake kawowa shine akwai lokutan da idan kamar wasu daga cikin mutanen karkara sun zo gurin da ake bada wannan allura ko kuma asibiti,
a wasu lokutan akan sami kamar harassment ga su jami'an lafiya, musamman waɗanda suka fito daga karkara. Ta fito irin bata fito da tsafta za a ce ba, saboda mafi akasarin mutanen karkara za ku same su ba su cika ɗaukan ado a matsayin wani abu na mai muhimmi ba, za su fito da irin somehow yawa. So idan suka fito wannan su kuma za su ga su ma'aikatan lafiya ne, sun yi dressing mai kyau da sauransu, za su nan irin suna tattaɓa baki haka irin kamar dai ba kulawa ta musamman akan su waɗannan mataye namu da suka zo karɓar wannan allura. So saboda wannan dalilin wata idan ta zo aka ce ta kuma dawowa next time don a yi mata wannan allura ɗin, sai ya zama na gaskiya ta ce kawai wulaƙanci suke yi wa jami'an lafiyar, saboda su ba za su kuma zuwa su karɓi wannan abubuwan ba. A ƙarƙashin wannan duk da shi ma gwamnati alhamdulillah ana samun sauƙi, shine akwai language barriers. Misali duk da dai allura ce ta kaɗai da kuma gurin wayar da kai ake yi wa su waɗannan mata da na ƙananan yaransu, shine yanayin yadda ake language. Misali yanzu kamar duk turanci gashi ake yi, to idan kamar aka zo daga karkara ta ga waɗanda ake yi ɗin mutanen sun sha bamban da waɗanda take gani yau da kullum, yaren da ake a gurin yana shan bamban da wanda take ji misali, to shi ma yakan sa wata ta je to ai an je kawai ai mutane iri kaza ne a wannan gurin, shi ma sai ta ji kamar abin bata je mata yadda ya kamata ba. So amma wani ana samun canji saboda yadda kuka ɗauki ma'aikatan da suke aikin, kun ɗauke su mafi akasari a yankunan da suke, an ba su horo saboda su suke shiga cikin al'ummar domin su wayar da su kuma su masu wannan allura. Amma some places akan sami irin wannan matsala kuma ce zamana ba a sami abin da ake so ba. Abu na gaba wanda yake bada wannan shine har yanzu muna da shi abin da ya shafi kamar cultural da religious na al'ummanmu. Da yawa a baya-baya duk da yanzu har yanzu ana samu shine kakan samu malamai misali, wasu su abin da suka imani da shi shine rubutu misali kawai za su, yayin da yaro ba shi da lafiya kawai za su yi masa rubutu, su ya wadatar da su, ko su tofa masa addu'a su ce su ba su da buƙatar wannan immunization ɗin, ko da kai musu bayanin mahimmancin da wannan allurar take da shi, su sai su ɗauka kawai a'a ba su da buƙatar wannan abun, su in Allah da in sun yi tofi in ba su da lafiya ko sun yi rubutu suna kyauta zaton Allah zai ba su lafiya. So wannan ana shan fama da su gurin su yadda su karɓe ta wannan allura da ake ta yau da kullum don su san mahimmancin da take da shi. Abu na ƙarshe a wannan tambaya taki shine akwai socio-economic status wanda kusan sanin kowa ne halin da muka tsinci kanmu a yanzu. Gaskiya idan aka waye gari cewar ka tashi a gida baka da kuɗi, baka da abinci, to kuma gashi baka da lafiya, to babban abin da mutane suka fi mai da hankali a kai shine ya za a samu a ci abincin. In aka ci abinci, domin ta kansa cin abincin shi ma lalura ne. Wannan ana maganar shekara 2 ko kuma waɗanda ma suke ma ƙasa da shekara 2. So nan kuma ga wanda suke manya daga kan shekara 3 har up to shi mai gidan kansa ma da yake samarwa. So sun tashi gaba ɗaya gidan babu abin da za a kai baki. Kuma da zarar ta zo za ta ce to shikenan ba ni kuɗin mota zan je in kai yaro mara lafiya. Wannan idan ya tashi in ba sa ka ci ba, da ɗan da ba shi da lafiyar ko kuma da za a je a masa rigakafin da ita uwar, sai an samu damuwa a wannan lokacin idan ta tambaya. So wannan gaskiya ana cikin critical condition na poverty a cikin al'umma. Al'umma suna cikin wani hali ta yadda ba ma maganar lafiya ba, hatta abin da za su kai bakinsu yana musu wahala. So muna kira da gwamnati a nan ta kokari ta samar da hanyoyin aikin yi ga al'umma domin su sauƙaƙa hanyoyin da za su samu na yau da kullum. Wannan kaɗan kenan.
So I think I'll just try to summarize what he said. So he mentioned that different communities vary, and so their challenges are different. But some of the challenges that they face and the reasons why some people do not access these services include lack of knowledge on the importance of vaccination. So some people don't really understand why they have to get their children vaccinated, and this can affect. He also mentioned distance or access to some of the places to access vaccines, which he mentioned that thankfully these outreaches have bridged that gap because some of the outreaches actually get to go to the places where people can access them. Another key thing he mentioned, which struck out for me, was attitude of the healthcare workers. He mentioned that attitude of healthcare workers also affects people wanting to access these vaccines because sometimes the healthcare workers do not they kind of look down on these people in this community. And so that would affect them wanting to access these services. And even if they come out, the next time they wouldn't want to come out. Of course, there are other issues surrounding poverty and socioeconomic barriers, cultural barriers. These are all things that affect people's access to vaccines. That's just it in summary. And yes, I mentioned the attitude of it. So I'm happy again, it boils down to accountability, which you've put measures in place. So that can actually address that. And with the outreaches, we would be able to actually take the vaccines to these people. The good thing about the integrated services that we're doing is, part of what we're doing is educating people about the importance of vaccines and other services. So that would bridge the knowledge. And I think for us, what we've done is the language with which we present that, which is one of the barriers he also mentioned, helps to address that so that people in the community, you can bring down the information down to their level for them to understand the importance of these things. And I'm sure that will go a long way to bridge this gap. I know we've been talking and talking. I'm sure this is an engaging conversation. At least I've not seen anybody put their head down to sleep. So I believe that we're following it. Those online, I hope that you're also enjoying the conversation. I would move down to our partners. I know that we've been talking about sustainability, and while we know that it's important for government to take ownership, which they are already doing, and to sustain gains, we still know that there is a place for partnership with development partners. And so we want to ask you, sir, with the issues of all the dwindling funds and resources with regards health interventions, are there any innovative approaches that can be used to ensure sustainability of these interventions? From your perspective as a development partner, as somebody that funds health interventions, can you just shed some light on innovations that can actually sustain some of these interventions? Thank you.
Thank you very much. I think much has been said. But when you look at, or when we look at zero dose reduction and activities targeted in reducing zero dose, I think we need to first and foremost understand two concepts. And I believe perhaps that is why most of us, the supporting partners, including the government, are not getting it right or not impacting much. One, we need to look at the access to services as well as utilization. And talking about zero dose, 80%, just a rough estimate based on experience, 80% of our zero dose is as a result of what? Is as a result of poor utilization, not access. Because government and partners are putting much resources and much effort, which translate to good access. But however, our main challenge is utilization, which means the uptake of vaccine at whatever level, whichever vaccine, put it in whatever perspective, is at the lower end. Let me just digress a little. For instance, I was just collating the state data in this room this afternoon. And of the 44 LGS in the state as a whole, our access stood at 86%, January to May. It's a cumulative analysis. But the utilization is at 67%. You see what I'm saying? Now, let me come back to the issue of sustainability. And then maybe this thing will come out very clearly. If we are to sustain the gains that we are having now, or that we have been seeing now, government and partners had to re-strategize, especially in terms of ACSM, community mobilization. When you talk of poor utilization, that means there has not been mobilization. People are not aware. So I think we need to focus on ACSM activities and then enforcement of legislation by empowering the traditional institution. I know in Kano State, routine immunization has been part of the legislative list and it has been approved, but it has not been put to use. So if we want to sustain and build on it, this has to be legislated, and then the community, the traditional institution need to be empowered. That is one. And so also the approach in the reduction of zero dose that we are seeing now. Perhaps if we continue like this, we will not see the desired result in the near future. Why I'm saying so is that we have many partners, in fact in Kano, more than any other state in this country. And for that matter, all the partners are focusing on zero dose reduction. But then, however, our focus, the focus of all the partners is within a limited scope, just within a limited scope. This has to change to prioritize, and then we should also be focusing on LGS and communities based on data available, not willingly. Why I'm saying so, any partner that is coming to support in terms of zero dose will be coming with a mindset that I will be supporting Ungogo, or I will be supporting Bebeji, or I will be supporting Dala. This cannot take us anywhere. I think the proper way is for us to meet the state, sit with the state, review the data available, make analysis, and then let this analysis guide us to where we'll focus. And if this will be done, I think we will also...
Okay.
And
okay.
Sorry, lastly, we are talking about sustainability. I quite agree with the previous speakers, the director, the PM. Yes, the issue of accountability and coordination, these two entities are very weak when it comes to routine immunization line. Supervision, for instance, is only happening at the highest level. That is at the very optimal. That is optimal at the higher level. But as you go down, the supervision optimal. Where we have strong supervision is from state to zone, from zone to LGA, but from LGA to service delivery point or health facilities is very weak. And so also the enforcement of accountability framework is very weak at that level. Thank you.
Thank you so much for that. I'm going to ask you the next set of questions. Please, as much as possible, we can go direct and give the responses. Thank you so much so far. So talking about, he mentioned access not being a problem. Not solely being a problem. And so the question I'm going to direct is to our community leader. So what role do you think you have to improve not just access, but utilization of these services? So these services are brought to the community. They're now available across the service delivery points, immunization, wash services, nutrition. What role does the community have to ensure that these services are being utilized? If you can just give us that briefly.
So, abubuwa a gurguje kamar yadda kika faɗa, farko dai akwai yadda kuka ɗauki waɗannan ma'aikatan daga yankunanmu. Su koda bayan wannan program ɗin ya tafi kusan suna kusa-kusa da al'ummar da abin ya shafa, saboda haka za a ɗauka kamar ma suna nan ne. Ma'ana program ɗin yana nan, za su ci gaba da zuwa gidajensu domin samun wannan services ɗin. Sannan abu na biyu, za mu yi creating awareness a cikin al'ummarmu na muhimmancin su dinga zuwa suna karɓar ita wannan allurar yau da kullum domin za ta taimaki rayuwarsu da 'ya'yansu da al'ummarsu gabaki ɗaya. So bari in tsaya iya nan kawai.
So he mentioned that a key thing that can happen is ensuring that the people that provide the services are within the community and people of the community. Because what that does is the people within know these people, and they know that if these people are their own people, they're definitely bringing something good to them. And then on their own path, as religious and community leaders, they would raise awareness within their communities so that people know that these services are available and they can use it. And so I'll move to our PM, still on the same line. The WHO focal person mentioned using data, as an important thing. So I would ask you, from the coordination point of view, what have you done, or what are the key things that can be done to ensure data-driven decision-making in provision of these services?
That's why it is essential to note that we have a body at the state, at CERIC level, whereby the gurus are there who can key into the data and fish out who is doing well and who is doing otherwise, so that a collective decision can be taken. Let me cite an example. Recently, we noticed there was an issue targeting coverages across all the 44 LGS. So we sat at CERIC level and fished out 2 best performing LGS and the 2 worst performing LGS. So even for those 2 LGS that are doing well, we say, let us go and confirm. Is there dark green really dark green? Is there yes, isn't it? And for those that are woefully performing, we also compose a team to go to the LGS and ascertain the reality, isn't it? So this is really a good innovation that data guide us in making decision and report back for proper planning. Thank you, and over.
Thank you so much for that. So we're beginning to round up, and so Dr. Sagir, sorry, it's Dr. Sharif, apologies. I have a colleague that is Sagir, so the S. As a way to round up, could you just highlight, maybe you can list in summary, what opportunities we have for integrating other services, the RMNCA, routine, reproductive, maternal, child health services, into our RI services, which is part of what we did with the outreaches. So are there list other opportunities that we can leverage on. Then with that being said, you can give us a final note on what sustainability in this context means to you, just in one sentence, please. That's after you've told us the opportunities. So it's 2 in 1. Thank you.
Thank you very much. I think this is a very good opportunity for me before I respond to a very good opportunity for me to speak with the community leader. Yes, because I'm always looking at what opportunity do I have to air what I want to air, so that people that needs to hear what I want to see. There's one important activity that needs to be happening in our LGAs at world level. Akwai abin da muke kira reconciliation meeting. I take that reconciliation meeting as important activity because we are tracking those children that have been missed in the facility. And that reconciliation meeting is happening a gidan mai unguwa ko gidan dagaci. Ranka da ka sani. And we are looking at the previous month's activity so that we look at who comes and who didn't come. Go? Yes, because people are coming with their register. Go? Code and type in. It's a register for you. DCM will come, Mengwa will come, and service provider will come with all their registers. And they are looking at the previous month's performance. And when they review, they look at what happened in, this is June, and they are looking at what happened in May. Oh? Yes, and everybody will see, Mengwa will say, I've registered 5. Service provider will say, I've registered 3. And then VCM will say, I've registered 7. So who has the highest number is BCM. So what happened to Mengwa that have 4? What happened to service provider that have 3? We identify those children that are missing. And the responsibility now lies with the community leader. It can be Mengwa ko dagaci, depending on our gida aka yi. Roƙon da nake shine a tabbatar ranka da meeting din nan ana yi. Not only ana yi, izama akwai quality a cikinsa. Not only mu zo mu zauna kawai mu ce mun yi reconciliation meeting, no. Kar mu zo kawai mu gaisa mu tashi, mu ce mun yi reconciliation meeting. What needs to happen at reconciliation meeting should happen. And what needs to come, who needs to come with what should be there, should come. Mai unguwa an ka ba mu sauran tuwo mun ci tsoki. In ma dai baka ba mu an ka ba mu soro muka zauna muka yi meeting din nan. Ni for me, an yi. Saboda we are trying to track wannan yaran da aka yi missing ba su zo ba a tabbatar an kai su. Mu mai unguwa kai muke dora wa dama responsibility mu ce to ga yara guda kaza ba su zo ba. Ka san su ko mai unguwa ya san su. Ya za a kirawo su, ya za a nemo su, mai unguwa shi ya sani. So thank you very much. This is my prayer to you. And I know there are a lot of structures we have that we can say we can sustain this. I cannot just discuss all. But what I know is we have a coordinating body, that is the CERIC at the board level, that will ensure that all the opportunities we have a lot of opportunities in Kano, a lot of them, from the partners, government, and how do we ensure that we integrate these services in our facilities? We have them. So that which department, which agency, which department do we need to engage to ensure this activity, integrating these activities are happening in our facilities. So thank you very much.
Thank you so much, sir. Please, can we give a round of applause to every one of them? Thank you so much for that. That was a very robust discussion. So for me, the key thing that I've gotten from all our discussion is Kano is ready to sustain. They have put in structure, they already have structures in place to ensure that these interventions are carried out. Working with the community, working with partners, and ensuring that their accountability measures were on the road to ensure that our communities are free of zero-dose children and that community people have access to other primary healthcare services in their community. So with that being said, I think we've come to the end, but we'll just entertain 1 or 2 questions from those listening, because I'm sure people have been listening ardently. So please, can we get, how many people do we have so that we just take two? Okay, so three. Okay, so let's stop at three. Oh, wow. Okay, so please, I would like to indulge that those asking their questions should go straight to the point. If it's a comment, please just hit the nail as it should be. So thank you. Those that have their questions or comments, please, could we say them? Thank you very much.
Thank you. Great discussion, and I want to congratulate you, especially the anchor of the discussion. Two key takeaways that I've had from the discussion: providers' behavior and language barrier from the demand side. The community person is saying these are things that we really need to do something about. Not that they are not ready to accept and then mainstream what we're doing as an initiative, but they're now showing concerns that for us to get it right and get it more, there is a need to address providers' behavior and language barrier. On the innovations on sustainability, I just want to advise there is a need for such initiatives to be incorporated in our operational plans. The policymaker have mentioned, director clearly said government is ready to commit, and he believes this government is open doing in making sure that these interventions are to the benefit of the citizens of the state. So let us see these kind of interventions being incorporated in our plans. I understand recently there's going to be this annual operational plan that need to be developed. So these are initiatives that need to be incorporated, and let there be a budget line for this kind of initiatives so that the sustainability component will be very prone. Not necessarily relying on partners. Tomorrow partners may not be there. But once the government have owned these initiatives and they are incorporated in our AOPs and they have a budget line, it will go a long way in terms of the sustainability. The next one I want to really bring about is exploring the opportunities that are coming from federal. We are now talking about local government, empowerment. So resources, funding is very key if we want to talk about initiatives and sustaining good initiatives that are really working. Here we are piloting, but Kano is looking beyond the pilot LGAs. We want to cover the entire LGA. We want to showcase we are champions. Let other states come and copy what we are doing. So this idea of exploring resource mobilization, leveraging on local government autonomy so that we can be able to get more funding to that. That will aid in our sustainability component. Thank you so very much.
Number two, please can we go straight to the point again?
Thank you so much for an impactful section. My name is Nasmimuna Kamila Adamu, and I have some key points to mention here. The first point I have with regards to the community implementation of the project, the first point I have here is the issue of male involvement in reproductive, sexual, neonatal, whatever project it is to be implemented in a community, male involvement is very important. As the community representative mentioned that the women, that's the mothers in the community, need to get approval from their husbands for them to come out to the field of immunization. I think instead of relying only on the mothers to bring their babies to the field unit, why not maybe implementing 70% of the project targeting the men, that's the husbands or the fathers of these babies. As we all know, the men in our communities are the major decision makers. And when a husband or a father is aware of all these implementation strategies, it will bring a less difficulty in acceptance or in the uptake of this project. Male involvement, as a community health nurse, I would say that male involvement is very important in achieving community health projects. Then the second point I have here is the issue of community, local government area health workers. And I know the workers that are being employed to carry out this project are mainly from the communities, that's from the local government areas. So instead of relying only on the workers, maybe community health nurses choose and others, why not training volunteer village health workers, the traditional birth attendants that comes from these particular communities? I believe that these women or these mothers in the community will accept this project more when they see that the service providers are their community members that are within them. The issue of traditional birth attendants and volunteer village health workers. Sorry, the next point I have is the issue of incentives. Maybe as a method of encouragement for the mothers to bring their babies or to attend, maybe after the first attendance, a little incentives can be given to the mothers, maybe as a little token of money that serves as encouragement for the next visit. And this only doesn't imply to organizations that carry out this project. Thank you that we have the representatives or the representatives of the state governments from the Kano State Primary Healthcare Management Board. Why not, if this would be implemented into the methods of carrying out these immunization services, the issue of incentives, not only the organization, but the government also, if there might be this point of giving a little token to the mother, it will increase the uptake of immunization services. Thank you so much.
Thank you for this panel. My question just goes directly to the Dr. Babagana about the issue of access and utilization, the gap that we have between access and utilization. My question is that, do you have any research based on that? Because if you want to find the real, what caused these gaps, definitely there must be some research will showcase what are the problems and how can we solve the problem about the issue of the access and utilization. Then my second question is about the issue of, Hafiz has asked a question about the issue of why the number of unimmunized children in urban areas, as far there is a lot of opportunity at urban areas, but with still, by seeing the data from Nasarawa, there's still a little bit something that is worrying. Why is that? I think nobody answered that question after Hafiz asked that question. That is my own say. Thank you, sir.
Okay. Hello, good afternoon. Mine is a commendation for the TA Connect for the concern that they have included all the three levels of the Kano State, that state level, world level, zonal level, and the LGA level. Because I am the witness that M1Es, zonal M1Es, and zonal emergency officer are included in the supportive supervision at outreach session at that selected LGS. And also, secondly, the access that we mentioned by the Mr. Babagana is that I want to urge the NGOs to partake that how to boost our access, because our access is sure that we have an issue in the routine immunization in Kano State. So state has to stay and discuss thoroughly so as to boost our access. Thank you.
Okay, so thank you. Thank you. Thank you very much for the questions. So please, can we just respond to them as brief as possible? For the panelists, any question that was directed to you, please, can you just respond as appropriate? Yeah, okay, so we can start with you so that the director
Okay, all right.
Yeah.
Okay, thank you very much. The person that asked the question is also busy doing something. Okay, excellent. So I think what I said, our utilization is suboptimal. However, our access is a little bit higher than 80, which is the national cutoff. And the data is from DHIS, I said it here, which is the official routine immunization data outlet of the state. So you don't need to conduct any research. So it is an official data. Have I answered your question? It is from the DHIS, where Okay, so if I come to answer your question for Nasarawa, you will understand. So, but are you clear with this?
Yes.
The source of the data is the DHIS, which is the official data outlet for the state. That is where we got the data. Now, for Nasarawa that you were asking, coincidentally, Nasarawa is my cluster LGA. And we, at the level of SERIC, we had conducted a vigorous investigation as to why this is happening in Nasarawa. Last 2 years, 2023, Nasarawa was in category 4. Throughout, Nasarawa was in category 4. And last year, 2024, from January to September, Nasarawa was in category 4. But between September to December last year, Nasarawa managed to move out from category 4 to category 3. And I am happy to tell you today, Nasarawa from January 2025 till date, Nasarawa is still in category 3. Which means we have so many private health facilities in Nasarawa, that is the metropolitan, so many health facilities that are either not conducting routine immunization or conducting routine immunization, but they were not being uploaded onto the DHIS2 platform, which is an issue all over. So why you will be seeing Nasarawa data like this is because of these two reasons. We have so many private health facilities that are either not conducting RI or conducting RI but are not uploaded onto the DHIS2. So once if this is done, I assure you Nasarawa is going to be one of the good performing LGS. So not only Nasarawa, this is the barrier or this is the compounding issue between rural and then cosmopolitan LGS. Thank you.
Thank you so much for that. So please, I would ask Dr. Sherif to maybe round up for us because we're actually done. Just the closing statement. And please, I would like to encourage that once we're done, let's not exit the stage. We'll just stand for a group picture. Thank you very much.
So thank you very much. I think before I make my closing remark, let me briefly respond to the, is it a community nurse? Yes, thank you very much. And I will just ask, are you in Kano? Are you in Kano? Yes, but you hear sometime of new incentive.
All babies are equal.
All babies are equal. You know them. You hear about them. We work together. Eh? Yes, now we work together. In Kano, throughout Kano. We work together in the 44 LGAs. What do they do? Yes. Yes.
They normally collect the data of the mother and the baby. Then after the vaccination, they give the, thank you. Then after the vaccination, they will give the mother, was it 1,000 naira?
They incentivize, it's okay. So they incentivize. What I want to tell you is we are working together. We ensure that vaccines reaches you. You don't have problem with the vaccine. We ensure that. So babies will come, you vaccinate them. No problem, no stock out. They will come, they will incentivize. Women, mothers will be happy, they will come back. No problem, no dropout, they will come. Issues of dropout will be seen. But what I want to say is we are utilizing them very well. We utilize them even during this campaign. We ensure even in the fixed and temporary fixed, they are there, looking at them. I was in one LGA in Ungogo. I have seen the turnout, tremendous turnout. People were there, caregivers were there, patiently waiting for their turn. We are going to continue working together with all the partners in Kano State. So thank you very much. Let me sincerely thank everybody for coming on behalf of the Director General Kano State Primary Healthcare Management Board. He actually wanted to be part of this meeting, but unfortunately something happened that he has to go and partake in that activity. So let me thank everybody for coming. I have seen the commitment, you've committed your time, we discussed, objective discussion actually. And actually we go back and look at the discussion and the implementers are here. We are here.
I just have a take. I just want to write on what my director was trying to reiterate. For the scale of, which is part of my prayer, issue of HPV, sir. HPV is really an issue in the state, so I hope in the next, phase 3 of TA Connect, HPV as part of the returnization process will also be included. Thank you, sir.
So thank you very much. And I wish everybody a safe journey back home. Thank you very much.
Very big round of applause for our panelists. They did great. Thank you so much for this engaging discussion. Right. So please, we'll go ahead. Sorry, over to you, Sunday. Thank you.
All right, thank you. Thank you so much, Dr. Jessica. Please, once again, a round of applause for our moderator and our panelists. Please put your hands together for them. Thank you. So the moderators and panelists, please stand up for a group photo, a photo together, please. Okay, let's make it snappy. All right, thank you very much. We want to thank you for your rich contributions throughout today's dissemination workshop. We've actually seen powerful presentations and insightful conversations. We witnessed from the panel session. And from all of those conversations, as an organization who has worked with the Kano State Primary Healthcare Management Board, we want to state categorically, and we also believe that we have not just achieved results, we also believe that this intervention has actually sparked possibilities. Possibilities for children who are unreached and they are now being reached with life-saving vaccines. And of course, we've heard so many conversations around innovations and what can be done to sustain this intervention. But beyond this, again, we want to thank our friends and our colleagues who are online. We thank you so much for your patience. We thank you so much for waiting through this entire conversation. We hope that this conversation will continue even beyond this room. We hope that with all the conversations, with all the suggestions, we want to see how the state continue in whatever foundation that has been laid thanks to this intervention. We want to also see how the state, through this intervention, is firming up its system to continue to improve vaccination uptake, especially for children in our hard-to-reach communities. At this juncture, we would like to appreciate everyone in this room for your time, for taking our time to attend this event. Of course, I've appreciated those who are online. We will now call on our multimedia folks to please display the Nigerian national anthem, the new national anthem. It was an oversight because it's something we did not do earlier, so we want to take that. So please, may I welcome you to please rise as we all go through the national anthem.
Nigeria, we hail thee, our own dear native land. Though tribes and tongue may differ, in brotherhood we stand. Nigerians all are proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace, all bow to honor it, and this we count as gain. To hand unto our children a banner without stain. O God of all creation, grant these our one request. Help us to build a nation where no man is oppressed, and so with peace and plenty, Nigeria may be blessed.
A warm round of applause for all of us in the room. Thank you. So as we draw the curtains on this event, I'd like to remind you and even our friends online that we will be sharing post-event resources online. You'll be getting that from TA Connect. Thank you, and please remain blessed. Yes, so before we leave, we actually kickstarted this event with prayer. So it is also important that we equally commit this event to the hands of God as we equally draw the curtains.
صلوا على النبي. ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إسرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين ربنا لا تزغ قلوبنا بعد إذ هديتنا وهب لنا من لدنك رحمة إنك أنت الوهاب ربنا ظلمنا أنفسنا وإن لم تغفر لنا وترحمنا لنكونن من الخاسرين ربنا عليك توكلنا وإليك أنبنا وإليك المصير ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار سبحان ربك رب العزة عما يصفون وسلام على المرسلين والحمد لله رب العالمين.